All right, okay. So, here we go. There you go, that's the bile duct, right? Full of stuff. And then the bile duct gets obstructed at the ampulla, pancreatic duct below. Reduce the height. Fluoro, where's fluoro? Call the fluoro from the other room. Where is Snehal? हाँ बोलो ना CDS के लिए है तो. Alright. Okay, here we go. So bile duct above, pancreatic duct below. So bile duct is not huge, 7.4 in the intrapancreatic portion. Then MPD is 6 mm. And this is not a good angle. You see here the scope the way it is. You can see on the screen up there as well. So it's not a perfect angle for us if we are targeting, because it's pointing more. It's good for rendezvous in this case. Yeah, but position. Now this is a little better for CDS. Let's see. Spot fluoro. Yeah, a little getting more vertical, more heading towards the sort of hilum. And this again, now here we go. So this is the hilum, and this below is the gallbladder, and this is the cystic above, right? Okay. So look at this. So this is your gallbladder. This is a thickened wall of the gallbladder. Interesting. It's almost cholecystitis like. And then this is your cystic here, I'd say. And then it would kind of open into the bile duct. So this is the bifurcation of the ducts, and this is the liver. And what you can see is a large amount of sludge in the bile duct, right? So if I have to do choledochoduodenostomy, I would prefer to hit the duct in the proximal portion, because you see the way the duct is. So each case is different. Okay, now you have to decide based on each case. Now this is hepatic artery, and this is your duct. And you see, if I have to puncture here, the duct is taking a sharp turn like this, and then it goes up, and then and then it goes into the intrahepatics, right? So you see the sort of the angulation of the bile duct suddenly taking a sharp turn. So that is not something I like. Yeah, Snehal? All right, so this is the intra-pancreatic portion of the bile duct. Come up here. So I think this is a good area to hit, but the problem is going to be if I think unless I really position the duct, the stent till where that artery is almost. And then it's okay. I mean, I'm going through the intrapancreatic portion. Spot fluoro. Yeah, but still the wire can be a little bit of a task to go across. The other option is to go up here, above all this jazz, and then this is sort of where it enters into the intrahepatics. So what we may do is maybe hit here, and then it still is an angle actually. It's not going to be that easy from there as well. And if I hit the duct here, then I'll potentially block one of the systems which I don't want. So this is a lovely angle, but I might find an avascular window, right? So it's lovely. I can do it. Not a problem. So I could go from here, get the stent in, but then if stent is here, then this will get blocked because you're using a covered stent. So I can't really go, I don't want to go here. What I may do is, I hit here. I think the problem is it'll probably go down at 6 o'clock, the wire. Maybe here and let it bounce off. So it's a tortuous duct. So it just goes right and then left and then right again. Okay. The other thing to do is whether we hit a lower part, which is somewhere here. Maybe let's try, but it's going through the pancreatic portion. Not the spot fluoro. This may be a little better, just because, if I can get the wire and my idea is going to be that stent goes from here and there's a straight up till here. That's it. So it's all straightforward. Right? So it makes sense to go from here. All right, ready? Needle? Snail? No, call right now. I have to get the wire in. I can't sit. Bula usko. Or I have to go and call her.
So what material?
Usko bolo call, you switch right now.
What material do you use?
Which wire? We use O25 wire, you know, when we do this. So again, now with us, this thing being here, it gets a little stiff now. Let's see if I can. Yeah, this is a good angle here, right? Okay. So I'm going to have her, but she's, let the technician come and then we'll. अरे कम फटाफट यार हाँ
This one below is PD, no?
PD is below, yeah, PD is below. There's one vessel up there. No, what do you mean puncture killer? If you're not here, if nobody's, if I don't have a technician, I'm not going to puncture the needle here. And then the other point is that you have to have a stable position, because if you are not in a stable position, then it's another problem. So you got to be in a stable position. I'm getting the needle hub out till, let's say, 2. This looks good here. Okay. And I'm going to first puncture, and maybe, I don't like to put contrast, but I may want to do it in this case just to get an idea about the duct. Okay. Yeah, this is fine. Spot. Brilliant. Aspirate now. Or actually, no, wait. First, let me go. Get some contrast ready. I'll need contrast in this case. See, that's not a good angle actually for CDS, but I'm going more by my EUS view. Okay, ready? Yeah, contrast. Yeah, fluoro. Live. Okay. See above, then it's going to make those sharp turns. Right? So the idea is that we just have to be till the turn, that's it, not beyond that. That's all I have. Okay? Okay, let's get the wash and put an NS and guide wire. You see that? So if I have to do it, then that's all, till the bend as much as I can and then come back. Or otherwise I have to do hepatico-gastro or proximal part. I like CDS.
Okay. So that was my question. Do you prefer?
I prefer CDS. So
or...
in this case, if I do hepatico-gastro and I really don't like CDS-wise, I have real problems then. The rendezvous could be done in this case, but let's see. But again, I don't like this whole exchange of wires and the shearing and stuff, so I don't like rendezvous. It's my preference.
They are quite dilated.
Yeah, I haven't really actually didn't see it properly. I was just focused on seeing a feasibility of CDS. Okay, now careful. Yeah. Lovely, going up. Fluoro? Yes, see, it's going where we need to be. Okay, perfect. Okay, good. Okay, exchange. Easy. All right. So not, obviously, different challenge here. The way the wire is going. No, 6 is okay. Right. So that's why if I had to puncture up, where I told you, I would have hit a complete 90-degree angle.
Yeah, which is not good.
Which is not good. Then you cannot put a stent. So that's why I wanted to hit in this manner where I'm at least having a little bit of a runway to the duct. Now obviously it's never going to go all the way down till the left of the screen, but as long as the stent reaches till the bend, I'm okay, because I mean 2 centimeters, 2.5 centimeters inside, it should be fine. So what happens with these CDS patients is they have these abnormal ductal anatomies, with the duct becoming tortuous and angulated and stuff.
And when do you decide to switch from CDS to
Hepatico?
hepatico? Yeah, when
Well, I mean, obviously, if it's really there's a big vessel or it's not feasible, I mean, 95% times I can do it. Now, if I have to hepatico-gastros only when, listen, man, there is, I have to target the left hepatic duct. Like last week, we had to do a specifically left hepatic duct, so we did it. Then we had, if you just can't reach the ampulla and you don't want to do choledochogastro and you can't find an axis, then you do this one. Or it's hilar block, right? If it's hilar block, proximal blocks,
yeah.
then you do hepaticogastros and ERCP not possible, and infiltrated ampulla, duodenum, those are the ones you do, when I do more of.
And,
Yeah.
do you
Okay.
perform
Ready?
pancreatobiliary
Yes.
procedures on
Pancreaticogastros, right?
altered anatomy in India?
We
There are
have
a
very
lot of,
little altered anatomy. Next change. Oh my god, this is a bad angle, man. Oof. Kaise re? Okay, I'm not happy. But we are going to have to get a lot of synchronization. Stop. Pushing. Okay, negative, pulling back. Again, 1, 2, 3, pushing. Okay. This is the problem one. This is going to be a challenge. Okay, so I have to do a lot of synchronization. Let's see. Yeah, so it's going to require nice. She has a deep wire in, so the wire is nice and deep, which is good because she's going to give me a lot of negative traction while I'm going to get across that part over there. You see that sharp angle?
Yeah.
That's going to be my main task. Once I'm above it, then I'm good to go. Chalo, quick, guy. Listen, fast. Okay. So this is again not textbook, not something you want to do. I mean, I'm doing it because I don't have a choice. Proximal would not have been there. Very up half would have jailed off one system. Yes, I could have seen a hepatocogastro would be the other option. We'll see. If I mess up this one, I'll do hepatocogastro. Obviously, I don't want to mess up this one, but yeah. Okay. So this is a problem. It's also a short wire technique, so I don't like that. Okay, wait. There you go. We got it. Cool. Done. We're sorted. That's fine. Okay, good. Ready? Deploy. It's okay. So just wanted to get it done.
angulation, but I think it will drain.
It's fine. This will drain well. Okay, very nice. Keep going. Yes. Keep going. Okay, stop.
50% done.
Okay, very nice. This is good. Okay, ready? Keep going.
That's a CHD na?
No, perfect. Keep going. CHD is very high up. Keep going. Keep going. Lovely. Done. Perfect. Ooh, sludge, yeah. Pus. Alright, fine. Alright.
Relative.
And the relatives. So yeah, we got half the stent here, half the stent up there. Supine, we'll change the position to supine. Okay, Shekhar, you can go to the other room. We'll do supine and then you can go to the room. Okay, switch the position, guys. How are we going to get a supine position? Okay. Yeah, so there was a sludge and there was pus, in fact, which came out almost. So again, I would not recommend doing such a case when you're starting out. This is fine. I mean, I've been doing it quite a bit, so I had the comfort of taking that risk in my maneuvering, but again, looking at the angles, the way things were, the sharp bend, sometimes can be a task. Then you mess it up, then it's a total shit show, because then you can't, then it's like bile leak and it's annoying, and then I've had my couple of bile leaks with such cases, therefore. Now let's see. Sorry, I'm going to interrupt 1 second. Yeah, I'll answer your question. So I want to see the left intrahepatic ducts as well. Zala, CDS done. Bhushan, Zala. Oh yes, it's done. See, the intrahepatics are not very dilated.
Yeah,
See?
so hepatico
Would have been. It said mildly dilated at IHD on the report, so I didn't bother seeing. But yeah, they're not very dilated. So I would prefer, CDS over a non-very dilated. So yeah, I wouldn't prefer going in this one. That bit of an angle was okay. Family? अच्छा दिखा. It's okay. अरे अरे. ठीक. It's okay. Oh yeah, look at this gallbladder. Distended, full of sludge. Yeah. Spot fluoro? Yep. So what are we dealing with here is, I think gallbladder and the stuff I mentioned. Okay, so that's one angle. The previous angle was actually better on left lateral, but it's 50-50 almost up and down. Perfect. Okay, so I'm going to pull out from this one. You guys can take a look if you guys